All right, welcome. We'll go ahead and get started. Thank you for joining today's webinar presented by the Tiny Baby Collaborative that will focus on antenatal counseling at 22 to 23 weeks gestation. My name is Noelle Young. I'm a neonatologist at Duke University in the US, and it's my pleasure to introduce our speakers and moderators today. Our first talk will be presented by Dr. Lex Doyle. Dr. Doyle is an emeritus professor at the Royal Women's Hospital in Melbourne, Australia. He's internationally known for his contributions to neonatal research, in particular in understanding long-term outcomes after very preterm birth. Following his talk, we'll hear from Dr. Marlyse Haward. Dr. Haward is a clinical associate professor of pediatrics at the Children's Hospital at Montefiore in the US. Her research focuses on decision-making, ethics, and communication with families of extremely preterm infants. After their talks, we'll have time for questions and discussion led by our moderators. Dr. Christy Cummings is a neonatologist, bioethicist, and researcher at Boston Children's Hospital in the US. Dr. Ashley Batterby is a maternal fetal medicine specialist and researcher at the University of Alabama in the US. And Courtney Veer is a mother, also in the US, and one of her children was born at 23 weeks gestation. Just a couple of quick housekeeping items before we get started. This webinar is being recorded, and the recording will be posted to our website, tinybabycollaborative.org, after today's session. We welcome multidisciplinary attendance for these webinars, including children and families. If you have questions that come up during the webinar, please feel free to submit them using the Q&A button in Teams. And questions that were submitted ahead of time in the registration forms have also been shared with the speakers and moderators. And questions will be addressed either within that Q&A panel or during the discussion portion at the end of the webinar. In attendance today, you can see that a little over half of the audience is made up of neonatologists, but we are happy to have participation of fellows, nurses, nurse practitioners, and other physicians, researchers, and parents in attendance as well from all over the world. On the registration form, we asked in your hospital who typically does antenatal counseling at 22 to 23 weeks. And you can see here that the majority of respondents answered that neonatologists and obstetricians both counsel families, but typically do so separately, while 22% answered that joint consultation with neonatology and obstetrics together is typically happening. We also asked how you think that families are counseled at 22 to 23 weeks gestation. When the counseling is performed by an obstetrics provider, 58% responded that counseling was appropriate, whereas a third thought that counseling was too pessimistic and 9% too optimistic. When the counseling is performed by the neonatologist, 80% responded that counseling was appropriate, whereas 10% thought too pessimistic and 10% thought that it was overly optimistic. All right, so with that, I will stop sharing and turn it over to Dr. Doyle to get started.
Okay. Thanks very much for inviting me, Noelle, and it's a great honour to present at this meeting, and it's the first time I've participated. I have nothing to declare. What I'll cover in this talk is a little bit about the perspectives, the outcomes, the choices, what should we do, and then finally give you some take-home messages. So firstly, the perspectives, and to give you an overall perspective, we all live in a society for which we're responsible for each other. But as a society, we can't make decisions at an individual level. So what we do is elect the government to do the thinking for us. And of course, government's role is to make laws. But the governments themselves don't make individual decisions. They delegate to health departments, who then delegate to health regions, who then delegate to hospitals, who then delegate to clinicians, the majority of the people on this call. And the clinicians are dealing with the individuals. In our case, the individuals are the babies and the parents. So we've got this all-encompassing society, babies and parents at the centre of it, and we've got obstetrics, and we've got pediatrics, and there's this interplay going on that we are all involved with on a daily basis. So what about the outcomes? There are several important outcomes, including death, major neurodevelopmental disability, which I'll define in a minute, survival free of major neurodevelopmental disability. Those three outcomes are mutually exclusive. You can only have one of them eventually. There are, of course, a lot of other medical outcomes to do with lungs or heart and any other organ system you're interested in. There are also emotional, functional, behavioural and society outcomes, and there are also parental outcomes. So they're all important. But in this talk, I can't cover all of those outcomes. I'll just focus on the three mutually exclusive outcomes. And to illustrate what I'm talking about, I'll use data from the Victorian Infant Collaborative Study Group, which has been evaluating intensive care for tiny and immature babies in the state of Victoria, where I come from, for a long time. In fact, going back to the 1970s, where the original cohorts were selected by weight. But more recently, we've had cohorts we can select by gestational age from four discrete eras: 91, 92, 97, 2005, and most recently 2016-17, where we have outcome data up to at least 2 years of age. And we always compare our preterm infants with term-born controls. This is important, particularly when it comes to adjusting psychological test scores. So just to put it into perspective for you, I come from the state of Victoria, which is the smallest mainland state in Australia, and the capital city of Melbourne is geographically almost in the centre of the state there. Our area is 87,000 square kilometres compared with North Carolina, where Dr. Young is based, a little bit smaller. Our population, nearly 7 million, North Carolina, nearly 11 million. Capital city of Melbourne comprises almost 80% of all Victorians, in contrast with North Carolina's capital of Raleigh. I think I said that right, very tiny, only 500,000. And in terms of total births, the actual births per head of population are pretty similar. In my state, the data that I'll show you have been derived from an era when we only had 4 NICUs. Now we have 5. We've had a new one brought online in the last few years. I have no idea how many NICUs or intensive care units there are in North Carolina, but you will know that. And I suspect it's far more than 5 and probably closer to 15 or 20. So in terms of what's been going on in the state of Victoria for those 4 cohorts, survival to at least 2 years of age has gone from a bit over 50% in 91, 92, increased to almost 70% in 97, then went back a little bit in 2005, and in 2016, 17 was getting closer to 75%. There hasn't really been much change, therefore, in survival rates since the late 1990s. At 2 years corrected age, we've seen the children and we've assessed them for outcomes including cerebral palsy, blindness, deafness, and developmental delay based on various versions of the Bayley scales, and they've changed over this period of time, which is why the controls are important. And we wrap this all up together in what I call major neurodevelopmental disabilities. So what is the definition of major disability? It's what you would call moderate or severe combined. So it's a developmental quotient more than 2 standard deviations below the mean relative to the controls. It's moderate or severe cerebral palsy, and then the gross motor function classification system, that's levels 2 to 5. So mild cerebral palsy isn't included. Blindness and deafness. And if you don't have any of those, then you don't have a major disability. So that will include developmental quotients from -2 standard deviations upwards and includes mild or no cerebral palsy. So that's the definition I'm using, and we can discuss that if you want later. So if we look at the rates of major disability or survival free of major disability, yellow is good, that's no major disability, and pink or purple, depending on your colour vision, is down the bottom, and overall it's around about 20%. But you can't look at preterm infants in isolation. This is the rates for each of those eras for the control groups, because children born on time also have disability by the same definitions. And so that's very important to remember. And overall for the tiny babies, it's 1 in 5 rate. For the controls, it's about 1 in 30. What this means is if you're working in disability services and a child comes along to you with a major disability in 2 years, there's less than a 1 in 50 chance that that child will have been born tiny or very immature. Far more likely to have been more than 27 weeks gestation and even more likely to have been born at term. So there haven't been really much change in the rates of major neurodevelopmental disability over time in my state. That's in the survivors. So we can pull the data and then plot these outcomes by gestational age, which is what the focus is here. So this is the survival rates for each individual week of gestation, going from 27 weeks down to 22 weeks. And you can see there's a little bit of survival at 22 weeks over these 4 eras. And this is the major disability rate at 2 years in these survivors. You can see how it rises with diminishing gestational age. However, the absolute numbers of children are not huge. You've only got 2 survivors at 22 weeks, 31 to 23 weeks, and increasing numbers at the other gestational ages. So if we look at these 3 mutually exclusive outcomes and put them all together, this is what you find. So here's survival free of major disability in yellow. There's a little bit up there. Survival with major disability in pink. And then grey is death. I just look at the last 2 years when the survival rates were a bit higher than in 91, 92. You can see it expands these coloured areas. However, that's probably not the correct denominator to look at. What you want to know is if you offer active care, what happens? So if we look at the outcome for those who are actually treated, offered care, you can see you get a lot more yellow and you get a lot less grey. In other words, more survivors free of major disability relative to the other groups. That's just to show you the overall cohort, how it makes a difference. And what about other studies of infants from 22 to 25 weeks who've been followed up to at least 2 years where they've been offered active care? And around the world, there have been large cohorts from Japan, Sweden, United Kingdom, another state in Australia, our data, and the US from the NICHD network who produced data on children born in years going back to as early as 2003 to as recently as 2018. And these studies are ordered on chronological year of birth. And the absolute numbers who have been offered active care, here's the Victorian data for 22 to 25 weeks. There's not that many, but there's much larger numbers, over 7,000 total. So we've got more stability, if you like, in the rates. And if we look at those 3 mutually exclusive outcomes of all those data combined, here's the survival rates free of major disability, survival rates with disability and death. And they're really much the same pattern. That's the Victorian data alone. That's the overall combined data. But here the difference is, there's the numbers for Victoria. These are the combined numbers. Now we've got much larger numbers to be more certain. And what it means to me is that what's going on in Victoria is much the same as what's going on in the rest of the world, as long as you're offering active care. The reason there is so much variation in rates around the world is because they include all babies. They don't talk about those who are just offered active care. So what are the choices? There are 2 choices. You can provide no active care. This blanket policy is not really supported by the data because it's not futile. In other words, it's not 100% universally bad outcome less than 24 weeks. And if you treat at 24 and 25 weeks, why not at 23 or 22? Because there's a gradation, not a falling off the cliff where everyone under 24 weeks is really bad. And the alternative is if you don't treat, they'll all die. So the other alternative is to provide active care. So just to highlight the contrast, here's not offering active care, all die. Here's what happens if you do offer active care. This is using the combined data I just showed you. And you can see how 23, 24, 25 weeks, the contrast is quite stark. So they're the 2 choices you got, yes or no. They're the outcomes that you would expect. Is my slide not working? Okay, so what should we do? We obviously, looking at this paradigm, we need to have a discussion. We need to talk about this with families and work out where to go. And this discussion needs to be a three-way discussion: obstetric, paediatrics, families, work out collectively how to proceed. That's all very well, as long as you're providing accurate data. And then Noelle's introduction, she said, neonatologists thought they were pretty good providing accurate data. Well, how good are they? A number of years ago, Rose Bolland, who was doing her PhD, she's a neonatal nurse, she worked with our group, and still does. She was doing her PhD and she did a survey of the health specialists in the state of Victoria, which included midwives, nurses, obstetricians, neonatologists working in and outside of the tertiary centres, and also the transport team. We have a statewide transport team, and they are the first port of call generally in terms of advice, what to do. They were asked to estimate survival and major disability rates in infants at 24 weeks gestation, both inborn and outborn. And this is the responses. So these are the groups: the midwives and nurses, the obstetricians, the tertiary centre, the transport team. The true rate of survival for an outborn 24-weeker was 37%. And overall, these are box plots. Here's the median. Overall, they're underestimating survival. And in terms of major disability, the true rate was about 1 in 3. They're all more than double that rate in terms of their prediction of outcome. So they were bad. They were underestimating survival and overestimating disability. Same pattern for inborn, perhaps not so marked for survival rates, but still as bad for disability rates. Again, overestimating the disability rates in survivors. So clearly they were underestimating survival and overestimating major disability. And I'm sorry, the bad news is paediatricians are as bad as anyone else. They're not better. So the survey was repeated in 2020, so 10 years later, for infants 23 to 25 weeks, where they were asked to predict survival and disability rates in a number of scenarios that covered those gestational ages. If we compare the differences in survival and major disability rates, that's taking true away from predicted in infants at 24 weeks. For the first survey, that was the underestimation of survival. In the second survey, it was even worse. And in terms of major disability, that was the first survey and that was the second survey, again, even worse. So were we any good at predicting outcomes? Not very good. Seriously underestimating survival and overestimating major disability and heading in the wrong direction, despite people telling them these are the data. So we really needed to provide better data. So Rose decided, well, we'll create a smartphone app, tell people what they are so they've got it at their fingertips. So she was able to get data for 1 year survival for all births in the state of Victoria for 2009 to 2017. That's a 9-year period. And there were 869 live births free of anomalies in whom active care was offered. And the variables that were associated with mortality were lower gestational age, being outborn, not born in a tertiary centre, being male and not having antenatal corticosteroids. I don't think any of that will surprise you. In terms of the survival rates to 1 year for this period of time, you can see what they were. They were around about 50% at 23 weeks and increased with increasing gestational age. And note that there are bigger numbers here to actually hang your hat on. In terms of major neurodevelopmental disability, we looked at our Victorian data for the first 3 cohorts I was telling you about, but this time at 8 years of age, because 8 years is a much more stable estimate of future functioning in contrast with 2 years of age. And we had almost 500 survivors where we could use those data. And the variables associated with disability were again lower gestational age and male only, not steroids and not being outborn. But we can combine all this together, and the major disability rates at 8 years are about 30% or 70% without disability at 8 years at 23 weeks. And you can see it's just nearly 80% at 24 weeks and just over 80% at 25 weeks. So here's the smartphone app, and that's its URL. You can download that and use it right now if you want to. But what you'll see is there's gestational age here, there's sex here, there's corticosteroids or not, and there's whether you're inborn or outborn. So what you do is you enter the information. So for example, 23 weeks, female, inborn, antenatal corticosteroids, it will tell you these are the three mutually exclusive outcomes. Chance of death, 35%. Chance of survival free of major disability, 51%. Chance of survival with major disability, 14%. You contrast that with the 23-week male outborn, no antenatal corticosteroids, you see the mortality rate is a big increase. It's double what it is for the female born in the right place with antenatal corticosteroids. So does Nick Predict work? Well, the first step along the line here was to repeat the survey, which Rose did just recently, and the results are in press in our local obstetric journal, which will be out very soon. So the survey was repeated for infants 23 to 25 weeks, and people were provided with 6 different scenarios, varying the gestational age, sex, inborn, outborn, and corticosteroids. They were asked to use the app and provide data for mortality, survival without disability, and survival with disability for those 6 scenarios. And we then worked out the overall accuracy. And you can see 80% of people got the mortality spot on. In other words, they were able to use the app quite correctly. However, the range of the data is from almost 40% below to 60% above. In other words, they either didn't use the app or they just ignored the results. Similar, the difference compared with the null value of 0 was negligible. In terms of survival with no major disability, again, 80% got it right, but again, note the variation. And in terms of survival with major disability, here again, 80% got it right, but note the tail is to the right. In other words, they're systematically still overestimating major disability rates in survivors, even though they've got the numbers right in front of them. However, this is better than what it was in 2010 and in 2020. So at least the information is getting out there. So does it work? Well, it does improve the accuracy of outcomes. But does it result in better health outcomes? Well, we don't know that yet because we need to see, are more babies being transferred in utero, are more being offered active care, and are more surviving? So this is the scenario that we've got. So clearly we need to have a discussion, but we need to provide accurate data. Family can't make decisions without accurate data. And clearly, as you're having these discussions, you need to be listening. What do the family want? Be guided by their wishes. So what's happened in my state is interesting because the health department, perhaps pushed along by the government, in the end of 2020, released some guidelines from a government agency called Safer Care Victoria. And in the guidelines, they talked about a zone of parental discretion at 22 to 23 weeks. And they wrote this: consider active management following live birth from 22 weeks, but only in ideal circumstances, such for babies born in a tertiary level 6 perinatal centre and for babies free of adverse perinatal risk factors. Now, did they really mean that you would only treat a girl at 23 weeks who was inborn with corticosteroids, but not treat a boy who was outborn and didn't have antenatal corticosteroids? I don't think that's what they meant. But we've got to be careful what we wish for, because once governments get involved and start to make laws, you end up in a hell of a mess. And I think in the United States, you've had far more recent experience of that in your country with laws dealing with abortion, for example, that have been interfered with by politicians, and then you get into chaos. So we don't want that happening in this space. Thank you very much. So what does this mean for Victoria? Clearly, we need to update our prediction model, Nick Predict. You may have noticed it didn't have 22 weeks. Why was that? Because no 22-weekers were offered active care in the whole state in that 9-year period. That's why there's no 22-weekers there. But now we are offering care to 22-weekers. We need to update the app. In the meantime, if we're going to offer active care, then you need to transfer in utero if you can. You need to give corticosteroids if you can. And clearly, if you can buy time to get them to the next week of gestation, they're going to do much better. And that's clearly what we're all trying to do. So what are the take-home messages? We have to remember anything we do with our families affects us all because we're all part of the one society. To me, the focus should be on survival free of major disability, but you have the choice to make your decision about which of the three mutually exclusive outcomes you want to focus on. It's up to you, but that's my focus. Clearly, we either do or we don't offer active care. And when we do, either way, we need to have a discussion, but provide accurate data and listen to the family's wishes. So should we provide active management to infants born less than 24 weeks? Yes, but only under some circumstances. Not universally, but not never. There's a balance. I need to acknowledge my collaborators in the Victorian Infant Collaborative Study Group, and now led by Jeannie Chong, and also those who developed Nick Predictor, led by Rose Boland, and I thank you for your attention.
All right, so I guess I'll get started. Thank you for that great talk. Share my screen. All right, so now we're going to roll right into antenatal consultation. I'm excited to be here. I want to start off by saying this talk will have viewpoints from parents along the way because I don't think that we can do any of this research without their opinions. I hope that by the end of it, you're left with some tools that might be useful. I have nothing to disclose. When parents present at 22 weeks in extreme preterm labor, they have many challenges. The first is that things are unfamiliar for them. They say they're handing over the lives of their baby in the hands of people they've never met before. They have overwhelming emotions. Oftentimes, parents will say they're in a fog, but they don't remember meeting or speaking to the neonatologist until after. There's a lot of uncertainty. One parent says, I saw a pistol with 5 chambers and 4 bullets. Russian roulette for my daughter's life. Would I gamble on 20%? And there's a sense of urgency. This parent said, I was so sick, I needed to get this baby out of me. Don't come and speak to me about statistics. Indeed, we know that about 1 in 10 parents who present at 22 weeks will deliver within 2 hours. About 40% will deliver within 12 hours, and close to 65% will deliver within 24 hours. So imagine trying to make a decision in one day. We know that one size does not fit all when it comes to making decisions. Some parents will try to protect against the burden of NICU treatment. Other parents will be worried about the long-term outcomes for their child or their family. Some will consider survival. Others will be guided by their religious beliefs or hope. Other parents will try to focus on what it means to be a parent to them, trying to do what's right, a sense of responsibility, wanting the best for their baby, doing everything, quote unquote, or giving their baby a chance. We also know that there are differences in how people make decisions and the evolution of that decision-making process. Within a couple, one partner will be more emotional and the other partner may be more logical. Some people will say initially I'm making an emotional decision, and with time it can become more rational. We know there are differences in the content, the format, and whether they desire recommendations. This group of parents said, we disagree that every family needs a list of negative things. Some parents will want statistics and some will want the big picture. Some parents will want to make the decisions on their own and others will want recommendations. And we know there are differences in values and preferences. And this is a quote of a parent saying, you clinicians are going to come across different families that have different religions and different beliefs. And there isn't one shoe that fits all. So the challenges for us as we go in and do these antenatal consultations are how can we effectively connect with parents? How can we effectively empower them, inform them, communicate under conditions of uncertainty, and support them through their journey? We know that when parents present, they have extreme emotions, and we need to address this emotional crisis in order for them to be able to engage. We also know we need to work on building trust. A study that was done by Annie Janvier with parents of trisomy 13-18 identified 3 themes that help to build trust. 1 is being knowledgeable. 2 is showing care and concern for the baby and the parent. and 3 is supporting the parent. So to foster engagement, we need to do simple things. Even though it may be the middle of the night and we're super busy, we need to go in and give the impression that we have all the time in the world for this incredibly difficult situation. We do that with our nonverbal behavior. We sit down at the bedside, we maintain eye contact, and we introduce ourselves. Then we can explore emotions and start by saying, I'm really sorry that you're going through this. Tell me how you're feeling. Then we need to permit silence, because in the silence is when emotions will come out, when people talk about their fears and their values. And then we can reflect those back and normalize them. We can say many parents in your situation feel overwhelmed, angry, or sad. These are normal feelings. We show them how we're knowledgeable. And knowledgeable means personalizing the information. We can show them balance, presenting both the positive and the negative. And very importantly, we need to show consistency with our obstetrical colleagues. Even though, as we saw from the survey results today, as well as the literature, the recommendation is to do joint consultations with obstetrics. It doesn't frequently happen. So we need to at least make sure that that message is consistent. So to personalize, we can say, I told you about the statistics, what happens to a group of babies. Your child is not a statistic, and we will learn to know her together. And lastly, we need to show care and concern. If the parents are still there, we need to go back in and reconsult. We need to ask them if their baby has a name and use it frequently in conversation. Then after we've addressed the emotional crisis and we've started to build trust, now we need to empower parents so they can come to the table as equal partners. In the PICU literature, there's this concept called good parent beliefs, and these are mantras that parents with critically ill children will use to help them guide decisions and cope. These are things like, I don't want my child to suffer. Neonatal parents are a couple steps behind. They need to first feel like they're parents before they can start to develop these good parenting beliefs. We can do that in 3 steps. So we can tell them, Lucy knows how much you love her. She has spent months listening to your voice. Enforce for them their parenthood. You can tell them they're not a bad parent. By alleviating their guilt, there's nothing that you did to cause this. Then we can say you have done a great job carrying Lucy this far. That has helped her tremendously. Because our goal is for them to be the kind of parent that they hope to be, even if it's only for an hour or for a day. Next, we have to inform parents. And in order to understand what to say, we need to understand how the parents in front of us make decisions under conditions of uncertainty. We need to know what values are important to them and what information is relevant for this decision. So under conditions of uncertainty, when people don't know facts and when values are uncertain, sometimes people will go to rules of thumb or gut reactions. These are quick, these are subconscious, and they can sometimes lead to biases. Other parents might be able to balance the risks and the benefits a little bit better. They might be more logical. This is more intensive and takes longer. We know that people can alternate between heuristic decision-making and rational decision-making, either as facts become more clear or values. We also know people have different role preferences. Some parents will want to delegate the decisional authority to a clinician. Others will want to involve family members or clergy. Some will want to retain decisional authority, as these parents say. It's a combination of everything, proper information from the doctors and proper support, and then it's your internal gut feeling. And some will say, God decides, it's not for me to decide. I could not be the one to decide if God chooses to take the baby away at this time, or just let it run its course. These meta values are the values that inform us on how parents want to make decisions, and we can use a tool, the sum parents, other parents, to try to figure this out. So for example, in the approach, we can say some parents prefer to ask questions first, other parents prefer to hear the information first. What would work for you? We can ask them about format. Some parents like the big picture, other parents want details. What do you prefer? But then we can ask them about their roles, making sure that we ask if there are other people that they would like present, if time permits. Next, we can look at how values inform content, again, using the sum other parent tool. In this case, the parent said she asked questions, and by asking those questions, that helped us to articulate our choices as it aligned with our values. So we can explore, what is your biggest fear? What are your concerns? Then we can reflect and show that we're a team, I also wish that Lucy has a good quality of life in the future. Are there other things that you hope for? If they haven't really been able to express anything, we can try to guide them. Some very loving parents value quality of life. Other very loving parents are worried about the NICU hospitalization. If they identify values, we can share content that's aligned with those values. And if we feel it important that they hear other information, we can gently explore that by saying, for some parents, long-term outcomes are helpful to hear, even if they are focused on survival. What would be helpful for you? Knowing that sometimes the information that we share is not necessarily going to inform their decision-making, but can help prepare them for next steps. What information is relevant to the decision, we can use personalization, which was described nicely by this group of parents. Each baby is different, have a personalized approach. You can tell us the general statistics for the gestation of our child, but what are the specifics about our pregnancy or our infant that will influence his or her outcome? And then we personalize for the family. Literature reviews have shown that people want more than just the statistical information on morbidity and mortality. They want information tailored to their questions. And very importantly, they want realism. They don't want pessimism. They don't want optimism. They want realistic information. There are some threats to being able to receive this information. Sometimes we provide too much or irrelevant information. There are differing perspectives between the clinicians and the parents. There are biases that impact risk perceptions, and how we present information under conditions of uncertainty is important. So sometimes we provide too much information. In this study done by Feltman and colleagues, they looked at MFM consultations and neonatal consultations. And on this box whisker plot, they show that there was a median of about 18 topics that were covered. So imagine having to review 18 topics if you're going to deliver in 2 hours. This parent said he went through the IVH, the PVH, the NEC, the ROP, the CLD, the RDS. And here I'm waiting for my baby to be born. Do I need to worry about asthma, or do I need to worry about the number of days she's on the ventilator? There are differing perspectives. We need to remember that 2 days before these parents presented, they were expecting a full-term healthy delivery in most cases. They were not ready to make these difficult choices. Antoine Payot has done beautiful studies on this, looking at how parents are still thinking of their pregnancy as the pregnancy project, and we are going in with the baby project. Parents are still grieving the loss of a normal pregnancy, and their goal is to continue their pregnancy when we're doing this consultation. So we need to address that emotional crisis before we just dive in and give them the statistics on the baby. Our long-term perspectives also are different than parents. Sarosh Segal has done a lot of work on this, showing how healthcare professionals and parents have differing opinions of the long-term quality of life. In this particular study, she provided clinical vignettes of 4 different children and asked the opinions of healthcare providers and parents. The y-axis is the utility scores. A utility score of 1 is perfect health and 0 is death. And what you see in the red box is that for Pat and Sandy, healthcare professionals thought that some of them thought that their condition was worse than death, but none of the parents did. So we have differing perspectives on the long term. And then there are biases, and biases are important in altering risk perceptions. So the availability bias is when you have vivid memories that impact the perception of the frequency of an event. So if this is what parents see all the time about miracle baby born at 19 weeks, when you're counseling them at 22, 23, or 24 weeks, they're going to think survival is extremely frequent. Then there's the anchoring adjustment bias, and this is where first impressions anchor future perceptions. We did a study where parents made decisions about 23-weekers, and we asked them, what motivated your decisions? And they said it was the neighbor's 32-week infants. So one of the things that I always do when I go into a consultation is I will ask them, do you have experience with prematurity? And what is that experience? Because this can lead to biases. Then there's the saving versus creating bias that Annie Janvier and Marc Mercurio describes as neonatologists being overly concerned with impairment. And if you think about it, think about a 7-year-old patient who has cancer. We don't go in and say, we're not going to provide you chemotherapy because there's a risk of that your child will be disabled. This was described by an expert as the single most powerful motivating emotion in neonatology is guilt. And we feel bad if we create a baby who is impaired. Then there's also optimism bias. Optimism bias are the beliefs that one is less likely to experience a negative event and more likely to experience a positive event than others. This is different than hope and optimism, in that hope and optimism, people still have realistic understanding of the outcomes. And we did this study in neonatology as well, where we showed that there was almost a 20-point spread at the lower percentages in terms of optimism bias. Now, when we communicate and people's values are uncertain, we have to be careful. There's something called framing effects, where when you present information as a gain or a loss, it will trigger different types of decisions. And we did this study with a group of participants. And in these participants, their values were uncertain. So in the survival frame, they received information about survival, which was exactly the same, but the reverse of the mortality frame. So they received 25% survival, and in the mortality frame, it was 75% death. And similar with the severe neurodevelopmental impairments. And what you see is that in the survival frame, more people opted for resuscitation than in the mortality frame. Then there are also order effects. How you present information in what order can alter choices. In this study, they presented a survival pictogram with the green babies being survival, or a disability pictogram first with the purple babies living fairly typical lives, and they saw that people made different decisions. They received the survival frame first, they more likely opted for resuscitation. And then there's default framing, which has very strong effects. This is opting in or opting out. And in this study, we asked participants, unless you indicate otherwise, at this institution, we will provide comfort care for infants born early like yours, and vice versa for the resuscitation frame. This had extremely strong effects. There was a study done in which they videotaped antenatal consultations to see how do clinicians and parents engage with uncertainty. What they saw was that some clinicians tried to do more and more and more tests. And we need to know that that uncertainty never fully goes away. And in fact, parents will say, it isn't so much about the percentages as it is about our values. Janvier, Lorenz, and Lantos suggest start with the forest and then let the parents refine down to the tree. Start with broad strokes. Clinicians also acknowledged uncertainty with honesty and then moved on. Sometimes people are worried that if they say that there's things that are uncertain, people will lose trust, but instead it actually builds trust to be able to name it and then move on. Clinicians also use uncertainty to build hope, because parents will say there's always hope that we will deliver tomorrow. There's hope that we will spend time with our child and that we can survive the death of our child with positive memories. And probably the most important, I believe, is to build these relationships, because you can always have uncertainty in the science, but if you build a relationship and show that the process is something that parents can have faith in, that can help offset that uncertainty in the science. So in this case, the clinician said, until the day that we can predict the future, everything we do comes from good communication. I will tell you what I am thinking, and you share with me what you're thinking. There's no uncertainty in the process. The goal of the prenatal consultation is value awareness, where people have the cognitive information that they need and the effective insight to know how that will feel. And so when they don't know what their preferences are, it's very difficult to be rational, but there are even instances when they know what their preferences are, they know what the rational, logical decision is, but they still say, I want to follow my gut. And that is okay. So the last theme is supporting parents through relationships. In this study, they showed how important the antenatal consultation is in building that trusting relationships with parents moving forward, regardless of the outcomes. And indeed, parents who we interviewed who had lost a peri-viable child in the delivery room confirmed this. They said it was, this clinician made the experience as magical as it could be. And this clinician saved me. He said, let's slow things down. Let's try and prevent this from happening. So the challenges for us as we enter the consultation room is that we don't know these parents. We've never met them before, which is why it's helpful if the obstetrician can go with us because they already have a relationship. But if we use these processes of addressing the emotional crisis, building trust, and empowering parents, it can help build that relationship. We know from this webinar that data is conflicting and limited, and that physicians offer different things. The guidelines that are out there are varied. We also know that what we think we know may not be accurate. So there's been studies looking at, do clinicians really know if parents want to make the decision or not? And clinicians don't. Do they actually know which parents have made the decision before we enter the room? And sometimes even after the consultation, they don't actually correctly know what parents want to have done in the delivery room. And it's important to know that what we think is a good or a bad outcome is very difficult to define and almost impossible to predict. And that's because of the diversity in values and because biases influence perceptions both prospectively, like in the saving versus creating bias, and also retrospectively in things like hindsight bias and outcome bias. And also people adapt. So the questions that I leave you with are, if resuscitation is offered at 22 weeks, which survival statistics should we use? We know the statistics from other centers vary widely, but if this is the first couple 22-weekers that you're resuscitating, what statistics should you use? We know that survival depends on the proportion of infants that are offered resuscitation, and there's denominator bias depending on which studies you use and which denominators they use to describe their survival. And those that are not resuscitated may not be similar in terms of mortality risk as those who are. So survival among all life-born infants cannot be assumed to be similar to those who are offered resuscitation. We know that parents should be counseled that outcomes are still unknown and uncertain. And we've learned that we can't extrapolate data from older, extremely preterm infants to the 22-weeker. And then I leave you with this question, which is one that troubles me. If a center is not equipped to provide long-term follow-up, which should be a minimum of 2 years, should they be promoting resuscitation? So I need to thank my collaborators and as John Lorenz, Andy Jean-Philippe Baruch-Fischoff, the Mary Manganiello Fund of the Valley Hospital that made the research with the parents possible, and then all the parents who shared their very important stories. Thank you.
Well, thank you so much to Dr. Hayward and Dr. Doyle for some great presentations. I know it looks like we've already got some discussion going on in the chat, and thank you for everyone who sent in their questions ahead of time. We were quite impressed by all of the interest in this topic and really important questions. I will go ahead and get us started off. And I think both of you have touched on a number of these questions in your talk, so feel free to kind of elaborate or provide more clarity around them. One question that came up from a few different people was regarding giving statistics. So it sounds like definitely thinking about which patients want statistics to begin with, but then for those patients who do want kind of more objective data and numbers, is it better to give local data? Is it better to give national data? Does that change if your local data is better or worse than the overall national data? And kind of how would you approach that?
So
I can go.
Okay, so I guess I'll start. What I will say, what's very important is transparency. So parents are going to find out the statistics at different centers, and it's important to be very transparent and say, survival is possible, and some centers have better outcomes than others, and be honest about the uncertainty in the data and how difficult it is to really truly compare between different sites and different centers, and then be very honest and transparent about what has been the experience at your center.
My response would be to use the local data if you have them. The reality is that no one place has large numbers, and so it's say 22 weeks. You saw the absolute numbers that around the world were still not huge. So you're only talking hundreds rather than thousands or millions. So there's still not a lot of certainty in the data, but you do have to rely on collective data, but the most important thing is the denominator. You have to look at the outcome for those offered active treatment, not all babies. And the reason that the results vary so much between places is because there's different attitudes to offering active care. That's the major reason.
I would just agree with that from the parent perspective. I think if you share data that is maybe not at your center, you're setting your relationship with the doctors not for success. So you could create distrust when you later hear, oh, maybe the statistics here are more like 20% versus 45%. And you might feel angry with them and that they lied to you. And so I would always err on the side of being open with the center's statistics and leading in with that. And so I think that's important. That should inform what you tell your parents. Statistics around the world should inform how much you're willing to try to save those babies and the desire to want to say, oh, those babies can survive. So we should try to do that. But so I would say absolutely 100% agree with both of you.
Thank you so much. I'll add on. We received many other questions that were similarly linked to approach with counseling regarding outcomes, local versus national data. But related to that too was also when delivery was anticipated to be imminent, and how can you best tailor those conversations when especially time sensitive in those more imminent situations.
I'll start if you like. It's a long time since I've worked in the nursery, so please take my comments in relationship to no recent experience. I stopped working clinically a number of years ago. So, you know, in a lot of circumstances, you just don't have time at all. The baby is given to you. There's no chance for any discussion. But regardless of the timing, the discussions need to occur on an ongoing basis, hopefully before delivery. Hopefully you've got plenty of time, and hopefully the parents have more time to digest the information. But in reality, a lot of the times it is imminent delivery or the delivery's already occurred, but the discussions still have to be had. And all you can do is the best under those circumstances. You often don't have a lot of time, but you often, for somebody who's in active labour about to deliver, there's no way the poor mother can be expected to digest the information you're providing. So sometimes you just have to admit that, okay, I can't say a lot here. We'll do what we can with the baby and then try to have the discussion as time moves forward. But once you've started treatment, it is harder to withdraw it rather than not start it. But that's just a general comment, and it's always possible to stop. And if the circumstances arise that the parents don't want you to continue or the baby's condition is so bad.
Yes, and I will also just add, you know, the simple things, the nonverbal behavior, the empathy that you show can still go a long way to creating that trust, and being honest about the process, about what to expect, is also very important.
And I can kind of piggyback off of that as well. When thinking about what outcomes you're discussing, we touched a little bit on this briefly, but when you're thinking about, you know, are we just going to include survival in your consultation? Are you including all of the other morbidities? Are you including short-term morbidities, long-term morbidities? What's kind of your approach at what things to discuss during your consultation? And this is, you've got more time.
So you definitely talk about survival chances if the baby's offered active care. And the words that I would use concerning the children who do survive is, I would say there are some children who end up and they have major problems with thinking, hearing, walking, talking, or seeing, the sort of problems that by choice you wouldn't want your child to have. But I'd point out, first of all, that if you're born on time, perfectly healthy at birth, you've got a few percent of children in that category who have those problems. So that's really the starting point. We then have to come back to where we are with your particular pregnancy and your particular gestation and say, well, the rates for those problems, if they're already a few percent for children born on time, well, they're this much higher if they're born at 22 or 23 or 24 weeks, depending on what gestation you're talking about. that's sort of language I would use, and then try to see what further information the parents want. Do they want more detail? What does he mean by thinking, hearing, walking, talking, or seeing? And do I need to elaborate? Some people want more detail, some people don't. So that would be my sort of starting approach in terms of providing information, using those sorts of terms rather than technical terms like cerebral palsy. I'd use the sort of functional outcome, if you like.
I would also add it's important to talk about how the parents, how we see that outcomes are so dependent on or so influenced by the family environment. And there's a lot that the parents can do also with adaptation and with helping sometimes in how these outcomes play out functionally. There's been research to show that some of our long-term studies, those outcomes may not necessarily always align with what is stressful for the parents later on. Things like emotional, behavioral outcomes can sometimes be much more stressful for parents than a child that needs a hearing aid. So we need to evaluate what their values are, evaluate what's important to them, instead of going in there with a list of outcomes. Gauge it with them and go one step at a time. But I'm curious of Courtney, your thoughts on that too.
Yeah, that is one thing that, just to give some perspective. So my son has cerebral palsy, and one thing that, sometimes I've noticed people have seemed like they've felt bad for us because he has cerebral palsy. And anytime you choose to have a child and you choose to be a parent to them, you are choosing to enter into difficulty. And so will the hardest part of my life be that my son has cerebral palsy? I'm not sure. My other children who are healthy may have other emotional difficulties. They may later in life have some sort of childhood cancer or lots of unknowns. And so I think putting so much emphasis on the early stages of how difficult disability can be really can overwhelm the parents to think, if a doctor's telling me that this would be the worst thing possible, you really feel that. And the reality is, what we found is we've been able to, from the support of our doctors, nurses, healthcare providers, we've been able to deal with it really well. And so I would say the perspective is maybe from the healthcare provider, this is a really bad outcome. But the reality is, for lots of parents, and if you are a parent, this, there's a lot of other difficult outcomes. So I would say overemphasizing the difficulty of future disabilities is helpful, to be honest, but also to not overstate those things, because even with my son's diagnosis of cerebral palsy, he has grown through therapies that we've been, he's been active in, and it's far less of a burden than what I feel like I was presented earlier on.
Thank you so much for sharing that, Courtney. It's so helpful. That actually relates to some of the questions that we've received before the conference about balancing hope and realistic expectations. And I'd love your perspective on that, as well as Drs. Doyle and Haward. And some of our research has shown exactly what you had echoed, that parents don't want negative information repeated over and over. They want realistic information, and yet not false hope. And so how do we find that balance? And I think of it as, hope and realistic expectations as not mutually exclusive, and that we have to pursue both, again, tailored to each individual family and preferences. And so wondering your thoughts on that as well, Courtney, and then others.
Yeah, I think the biggest thing is to get through one hurdle at a time. And so even in situations where delivery is going to happen very quickly, the first thing I would say is talk about chances of survival. I think that's the first thing to get through, because you have to, as a parent, you're, for the first time considering, my child might not live, and I never thought that. And so trying to understand, getting through that first hurdle. And then I think if there's time and space, just like you guys, shared earlier, to talk more about potential outcomes outside of just survival. But I think the reality is to start with, let's talk about what is the chance of survival? And then after that, to, if there's space, to say that this is the what could happen. And so it feels first the balance of life or death. Okay, then what? And the things are not always as certain. I feel like later on. And so I would say starting with less information, honestly, right out the gate is really helpful in having a reality of your center's statistics, but also being willing to say this is a continued conversation that doesn't just happen right away. We will walk through your entire NICU journey. And what makes the NICU safe is the neonatologist who are continuing to talk to you, discuss with your child's outcomes, the test results, taking the time to understand. And so having that reality of the statistic, this is what we have, but we're going to walk you through each milestone of your child's life and each test and each study, whatever the child comes to, and we're going to walk together in that. And I think that makes it feel less like you have to share every single minute detail of outcome.
I couldn't agree with you more, Courtney, about the conversations being on a continual basis and repeated. It's not just one consultation at one point in time. It's many consultations that all through the journey, and it could be several antenatal consultations. Given if somebody, if there's time is sufficient, but certainly after birth things change quite quickly, and once you get through certain periods of time, of course, the survival rates go up compared with survival rates at birth, because you're most likely to die on the first day after you're born rather than any other day subsequently. That's the most dangerous day for everyone. And so things alter. And as you say, various test results or various things that happen to the child shift the prognosis up or down. So it's a continual journey, and it doesn't finish even when they go home. It continues long after they go home.
I think one of the things that you highlighted, which is so important, is that relationship with the clinician and building that trust and sharing the hopes. To get back to part of the hope question is, we also share the same hopes as you do, and we share the same goals as you do. And as things progress, if things change path a little bit, start to redefine hope. And what else can we hope for if this goal is not achievable? But using the language of hope sometimes is a good way to maintain that connection.
In trying to kind of doing all of these things at the same time, providing statistics and balancing, realistic expectations and also providing hope. Do you have any tools or resources that you use actually when you're discussing this with the patient and performing the consult? Decision aids, apps, things that are, patient facing to help communicate this complicated information?
In my hospital, when I was in active practice, we developed a number of information sheets, if you like, one-page summaries of the sort of information that parents might want to look at after you've left the room. Personally, I never used those up front. But they were something that might be left with the families, and then you come back later on. And then, as I said before, the circumstances change, but it gave some idea of what might happen to the child over the next little while. How long might the baby need help with a ventilator, all those sorts of things that happen during the NICU state. So yes, we did have written materials. I think they're still used today. As I said to you, I don't work in the nursery anymore, so I'm not active in this space. But I think the same information still is provided in one way or another.
So I think it very much depends on the parent and what's going to work for them. And I think similar to what information do you share, it needs to be a dialogue between what is going to help them and what isn't going to help them. For some parents, they may only want to talk about survival. I'm backtracking a little bit, and other parents may want to dive deeper into other outcomes. But in terms of decision aids, the relationship has to come first. So if you walk in the room with a decision aid and make that the first thing that you talk about, that's not going to build the relationship. The relationship has to come first. And then some parents will want an information sheet. Some parents will want more data, and some parents won't. So I think it's very important to understand who is sitting in front of you, what is going to help them or not. And then when you make, if your hospital decides to make a decision aid or makes a tool, it must have parents involved in the process. Parents need to be involved to say, this would actually be helpful and this wouldn't, because just with our major outcome studies, we need to start to incorporate parents at the table so they can tell us, we really want to know about emotional outcomes in our kids, because for us, this is really hard. And so any decision aid should involve parents in its formation and asking them if it's useful to them or not.
Obviously, I'm not a part of any consults, but I will give perspective because I've had a child born so early. I've been a resource to many other parents. And my encouragement to parents has been, after you have a consult with your OB or the neonatologist, write down 3 questions. Every time you see them, have 3 questions ready for them. That way you can figure out, you can help them to understand what's valuable to you. You can make sure that you're processing the information really well. I don't know if a doctor would say that, if that would be helpful, but for me, that it's really helped the people that I've connected with to say, like, just have 3 questions before you see them, write it down, and that way you can understand the information and the things that are valuable to you are communicated. So I don't know if you should do that as a doctor, but it's been helpful to the people that I've walked alongside journeys with.
That sounds like a very good suggestion. And of course, the questions will vary quite widely.
I can ask another question. So there can also often be conflict between the OB side and the NICU side in terms of kind of even from the counseling standpoint, as we brought up, kind of one of the questions that we asked everyone is kind of, how do you feel that the counseling is by OB compared to NICU? Is it too optimistic, too pessimistic, just right? And there were definitely some differences, even in kind of your perception of that. I'll just kind of start with the open-ended. What would be your general approach if there is kind of a discrepancy between what the OB consult is providing or the NICU consult is providing? Or how would you try and, prevent that conflict before it ever, arises?
Could I start off? Your survey is interesting to me because 80% of the neonatologists thought they were doing a good job. Well, sorry, at least 80% of the respondents thought the neonatologists were spot on. But unfortunately, the majority of people on this call are neonatologists. So of course they're going to think they're doing a good job. If you had all obstetricians, I suspect you get a different response. But my data, not my data, Rose's data that I showed you, pediatricians are as bad as the obstetricians, all the non-medical people. The survey was widespread in terms of health professionals and wasn't restricted to just doctors. It's important to point that out. And more worrying to me was the transport service is the first port of call. Somebody in the community will ring that service for advice for both obstetrics and neonatology. And if the people at the other end are providing the same inaccurate data, heaven help people making right decisions. So we shouldn't consider ourselves as being more accurate and more holy than the obstetrician. We'll never get anywhere by doing that. I must say my clinical experience, rarely was there a discrepancy between the obstetric and the pediatric staff. And that primarily occurs because the obstetrician only asks the pediatrician to be involved when they're not certain. If they're already sure about what they're going to do, they won't necessarily ask the pediatrician unless that decision is for active care. If they've already made the decision, no active care, more often than not, they won't ask the neonatologist to become involved in the counselling. So you get filters along the way, and that's probably why I never saw a whole lot of, as you say, disagreement. Usually you can talk it through with obstetricians and the families hopefully together if you've got time to work out which is the best way to go. But it's not such a common circumstance that I came across.
I'd love to weigh in there too, because a lot of the qualitative work we've done with parents at extreme prematurity actually showed that they can and do pick up on the team synergism and when it's working well and particularly when it's not. And they lost trust in the teams when they noticed discrepancies or miscommunications or poor communication between shifts. And so I think that's actually really important. And one of the major themes that emerged from our work is to ensure team synergism. And that can happen with, debriefing or a team brief huddle before the consult. If you can do a joint consult, sometimes that's not possible with scheduling feasibility, but at least a huddle beforehand to talk. If you can't do the joint counseling together and ensure everyone's on the same page, and then following up through just to really ensure consistent messaging and team synergism.
Courtney, in your experience, did you sense conflict and discrepancy between kind of the two specialties that cared for you, or and your son, or how did it appear to you?
Yeah, I think so I don't actually I live 2 hours east of the Iowa City, which is where my son was delivered. And so the information, even from across the state, so my son, born at 23 weeks, the University of Iowa has some of the highest statistics in the country for survival rates for 23 and 22 weekers. And my OB just 2 hours east did not know those statistics. And even a hospital that's closer by that had they resuscitate at 24 weeks did not share the information that Iowa would try at 22 to 23 weeks. And so there has been, if you're not actually at the center, I've noticed this is maybe just in my state, but notice that there is pessimism towards what a center can do in resuscitating 22 to 23 weekers. And so one thing that I've tried to do just in my community is to make mothers and fathers, families aware that there are centers that are close by, that driving 2 hours east was absolutely worth our time because my son wouldn't have survived had we not. And so thankfully not at the actual, once I got to the University of Iowa, there was, they agreed continuity of what the plan was. But even if you're considering people who are seeing OBs at a local center who it's not actually at your hospital, there can be problems with that and some misinformation that's shared. So I don't know how you share your statistics and your practice with local hospitals around the area, but I would be curious to just make steps towards sharing the data, not as a way to, well, you should flaunt it because it's truly incredible, but as a way to make other OBs in the area aware of it. So yes and no, to answer your question shortly.
And I wonder if countries that have regionalization of care run into the same problems with the community versus the academic center and the statistics.
Our service is regionalised, and all the concentration for neonatal intensive care is in the one city, which is geographically almost in the centre of the state. But that's because, as I said, almost 80% of the people in my state live in that greater metropolitan area. So they're already located where their services are. And the people outside of those areas know that if you've got a problem with these sorts of gestations, you send the mother, hopefully with the baby still in the uterus, to those centres. So there's sort of not that problem of having to drive 2 hours one way or 2 hours the other. There's only one place you go to, and that's to Melbourne. And that's a transport service that operates both antenatally and postnatally. So that's why I emphasise the importance of the transport service, because they are often the first port of call. They're the ones that are giving the data potentially to the people in the community, and they're translating that to the families. So do you want to be transferred to the big city because this is your chances, or not? So it's very important that those people have the correct information.
I don't know if it's the right answer or not, but something that we did, which was really helpful to make sure that both from the maternal fetal medicine side, we were on the same page with our neonatology colleagues, was they created kind of a little laminated card that we were able to, put with your ID badge that just has some of the statistics by week for our center, to kind of share that data, because as an obstetrician, we don't get to, necessarily see those babies every day and have a good sense for survival and morbidity outcomes just anecdotally, because we're taking care of more pregnant moms and not following the babies as closely. So that was really helpful to kind of keep everybody on the same page. And then I echo what you just said. We, are a tertiary care center that serves, a lot of rural Alabama, and a common call that we'll get is about kind of peri-viability, and we can kind of go through those statistics and walk through an obstetrician on the other end of the phone to kind of walk through an initial discussion of what we could potentially do, what survival rates are like, to see if they're interested in getting in an ambulance and driving 3 hours to get to Birmingham, Alabama. So. We have lots of other questions that are more practice management, which I will just throw out kind of a general question, which is, we've talked a lot about 22 and 23 weeks. We know that the bar is constantly changing. And so what are your general approaches to counseling and, making a plan for a patient that has threatened preterm delivery at 21 weeks regarding steroids or 21 weeks or extremely low birth weight? So what would be your approaches to kind of lower limits of gestational age or birth weights?
Well, I'm not sure that there's very many outcomes that are available on. I haven't heard of much. I'll pass that to Dr. Doyle, but at 21 weeks and lower than that, we just don't have. I think on the first seminar, there was a resuscitation of a 21 and 6/7 weeker. Is that correct? Did I stand corrected on that? And it was very much approached as, we've never done this before, and we don't know what's going to happen. This is, for lack of a better word, quote unquote, experimental. But as far as I know, we really don't have outcomes at those much younger gestational ages.
Personally, I've never been involved in active management of anyone at 21 weeks. But just remember that the gestation isn't always 100% certain. In these days of routine antenatal ultrasound, you're much better off than what you were when I started looking after babies in the 70s, where antenatal ultrasound didn't exist, and 1/3 of women had uncertain menstrual histories. And even today with antenatal ultrasound, there is an inaccuracy in those gestational ages. And, a week either side can make a huge difference to the outcome. So keep that in mind when you're talking about 21 weeks. And whenever you see these miracle baby reports, baby surviving at 21 weeks, the first question I ask myself is, was the baby really 21, or was it a bit more mature? And that's why it survived. So should you be giving steroids from 21 weeks and 5 days because you like them in 2 days before, optimally? That's a discussion that you would have antenatally with the family. If the decision was to treat actively from 22 weeks onwards, then you might want to do that. On the downside, you might be then subjecting that mother and fetus to repeated courses of antenatal corticosteroids, because we know the prediction of imminent delivery is not necessarily 100% accurate either. And we've all had babies or pregnancies where, the baby's coming, and then many days or even weeks later, still undelivered. And that's fantastic for the baby, but unfortunately, it does potentially expose them to multiple courses of antenatal corticosteroids, which in themselves may be bad. Having said that, the evidence is that a couple of repeat courses isn't probably too bad, but when you're getting up to 8, 9, 10 courses, because you're still undelivered 10 weeks later, then you're potentially running into trouble from exposure to antenatal corticosteroids. So there's a downside to using the corticosteroids too early. So that's not a conversation I've personally had or been directly involved with, but it may occur in individual circumstances. Fortunately, they would be very uncommon.
There is one question that just came through the chat that I don't think we've addressed, but is a good question. When you're talking about your kind of active treatment or your resuscitation, are there different, degrees of resuscitation that you offer? Is it an all or nothing? How do you kind of approach that from a counseling perspective, as well as kind of how would you practice?
A number of years ago, one of my colleagues wrote an article about trying to predict the winners. What they meant by that was, if you have the baby in front of you just being delivered, can you predict whether that baby will go on and survive or that baby will go on and die? And they produced a series of videos because at the time they started routinely videoing resuscitations. And they had, I think, 20 videos. And we were asked to say, well, do you think this child survived ultimately or not? In other words, you often hear the expression used that we'll resuscitate depending on how the baby responds in the delivery room. And if it doesn't respond, we'll stop. And if it does, we'll continue. Well, I think this study showed that, well, we weren't very good at predicting the winners. All the babies in the videos, of course, were continued in terms of active treatment. So it was a biased sample. But it gave you some idea that you really can't do it half-baked. I think if you're going to offer active resuscitation, you do everything you can. When I say everything you can in terms of positive pressure support and adequate ventilation, but not necessarily extensive cardiac massage and repeated adrenaline doses, epinephrine doses for you Americans, adrenaline to me. There's a limit to what you might do pharmacologically, but in terms of trying to provide the best respiratory support, that's what you would do. If the baby doesn't respond to that, well, okay, not every baby responds in the delivery room, and some die in the delivery room despite your best efforts. Well, that happens, but don't do it half-baked.
I also think it's not fair to say to the parents, we're going to try this, and then if this doesn't work, we're going to try this, and then what if we try this, and what do you want us to try, and what do you not want us to try? That's too much. It's not their job to say, you should try this, and then if that doesn't work, then you should try this, or you should stop here. That either they make an incredibly difficult decision about whether to pursue active resuscitation or not, and it's our job to know what that is. It's not our job to give them a menu and say, check off what you want. I think that creates a lot of anxiety and a lot of stress, and I don't think it's helpful to the parents, but it's my opinion.
One scenario that you might come across in this situation is in the delivery room, you are resuscitating as actively as you can, but the baby is not responding and the baby is going to die. And if you can have the conversation with the parents, and more often than not these days, the mother is awake, so you can have a conversation, at least with the mother, and hopefully the father will be there or some other support person. You might say to the family, your baby's not going to survive, not responding to resuscitation. I think the kindest thing we can do is to stop and at least give you the baby to hold for the last moments. Whether that, fortunately, whichever way you look at this, some babies still continue to have a heartbeat for many minutes or even hours. You have to remember that when you stop, the baby doesn't suddenly stop all signs of life. So you have to warn them of that prospect, that can happen. They can have breathing movements, they can have heartbeat for quite a while. But the families where I've had to do that have relished that, or not relished, they've trying to think of the word, but it's been very positive experience for them later on that they've at least been able to hold their baby during that dying process. I think that's been a positive for them rather than the baby's dead and here's hand over a dead baby. I think that's, if you can give the parents that opportunity, that's important.
And I think you can also give them the warning shots. We're trying this, it's not going well. We're going to try one more thing. If it doesn't work, then we're going to stop. And you give them the warning shots. You give them 3 steps or a couple steps, and then you just be very certain in how you're doing the steps in order to prepare them.
I think we have just a few minutes left, so I will thank you guys again for coming. Thank you to all of our viewers today and for the Tiny Baby Collaborative for organizing this webinar. But I will leave it to you, Dr. Doyle and Dr. Hayward, and Courtney and Christy, if you want to jump in on any last words, any kind of takeaway points that you want everyone to go home with today.
My takeaway point would be know the data and provide it accurately, or provide accurate data to the families when you are talking with them, and keep it in your mind. And if you're not sure what the data are, use Nick Predict. I mean, it's at your fingertips. You don't have to have a plastic card on your name badge. You can just get on your smartphone. Everyone's got a smartphone. It's right there.
I guess my take home point is that the antenatal consultation is not just a list of items and then ask people to make a decision as the end goal. It's a process, and that process has to address the mental health and the emotional crisis that the parents are in. It has to build trust. It has to do that in order for parents to feel empowered as equal partnerships. The information is not going to correct the power imbalances. It's the relationships that are, and those relationships need to continue, because this is and I think, Christy, it was your article that said that how the consultation makes people feel was as important, if not the most important thing to them, than what was actually the language that was used in that consultation.
I think I would just say thank you on behalf of parents who find themselves in this situation. You don't know what you don't know until you get to where you are. And so I think I'm encouraged by the amount of people who are doing research on this, who are willing to try, but even the amount of people who are on viewing this webinar today. So thank you so much. You, even if you cannot provide the best outcome for each family, you provide hope for them in a way that is so important and significant in their lives, whether their child survives or does not. And so I just want to say thank you. I appreciate your work, and has obviously affected my family so much, and we couldn't be more grateful.
Thank you so much, everyone, and Courtney and our panelists and moderators. Thank you. And to the participants, you had such wonderful questions that were submitted beforehand and as well as now. We do apologize if we weren't able to get to all of them, but that please feel free to reach out to us if we can be of further assistance. And thank you to Noelle and others for organizing this. We really appreciate it.